It's my pleasure. It's my pleasure to introduce Dr. Sangeeta Agarwal, who, after receiving her medical degree in India, Merit Medical College, went to internal medicine residency in Valhalla and Hemong Fellowship in New York, Mount Sinai, and then was attending at Albert Einstein, and then moved to the West Coast in 2005 at Santa Clara Valley Medical Center in San Jose. And she's been specifically interested in breast cancer awareness and clinical studies and mentoring residents over the year, and has been involved with ASCO, ASH, AMA, and API, and also the Chief Medical Information Officer of Scry Analytics, as in charge of the company's portal and Voice of Cancer Patients. So essentially, she's a she's published many articles and actively involved in research um, and for this breast cancer month awareness month, we couldn't think of any better speaker than her talking about what is more important to overall health of women out there, which is breast cancer updates. So Dr. Agarwal, welcome. Thank you.
Yeah. Thank you so much for inviting me to give this presentation. As we all know that October is a breast cancer awareness month. And since breast cancer is such an important disease, I would take this opportunity to talk about updates in screening, guidelines, risk stratifications, prevention in the high-risk population. Are you all able to hear me and see my slides? I just wanted to make sure.
Yes.
Okay, great. Thank you so much. All right. So as I mentioned before, breast cancer is one of the top cancers in United States, followed by prostate cancer and the lung cancer. According to the latest CDC statistics, more than 272,000 new cases of invasive breast cancers are diagnosed every year in US, and it accounts for more than 42,000 breast cancer deaths per year, which is a staggering number. This actually results in incidence of female breast cancer of 134 per 100,000 female population in US. And 1 in 8 women born in US will develop breast cancer. So that results in the lifetime risk of developing breast cancer of about 30%, which is significantly high. And if I look at the trend from at least since the data is being kept from 2000, early 2009, and now, the risk is actually increasing slowly and slowly. In US, the risk is almost stagnant, but in many parts of the world, the risk of developing breast cancer is increasing on a yearly basis. Continuing with the statistics, the good news is that 2/3 of the breast cancers are actually diagnosed at a localized stage. So, if with all these developments in breast cancer diagnosis, treatments, as well as screening and prevention, overall survival of all the breast cancer in all stages is about overall 5-year survival of breast cancer is 91%, which is pretty remarkable. And the overall 5-year survival of localized breast cancer is 98%. Whereas it's only 32% for metastatic breast cancer. So even more important to diagnose these breast cancer early and start treatment early for much better survival and prognosis. Again, I'm not including in this statistics the demographic variations, such as even though the incidence is higher in white women, the mortality is higher in Black women. We don't have very good granulation in different other ethnicities, but this is what we have right now. I try to find these similar statistics for India, but they're all over the place. So I will today in my presentation I'll talk about the US statistics. The good news is that the mortality from breast cancer is constantly decreasing since the beginning of 2000. Actually, if you look at all the cancer mortality, it is slowly decreasing, sorry, in 2000s. So again, you know, putting the importance of more research and newer methods of treatment. So how can we impact the mortality of the breast cancer? So there are, multiple ways. First, identify the risk factors for breast cancer and possible use prevention strategies. Second would be surveillance and early detection of breast cancer, as we saw that early breast cancer, when treated, has a 5-year survival rate of about over 98% or so. Once they are diagnosed, early treatment, including all the treatment modalities, the improvement in the treatment of metastatic disease, and also a follow-up survivors of breast cancer. They all contribute to the improved mortality from breast cancer. So in my talk today, I will concentrate only on the identification of the risk factors and possible prevention and surveillance and early detection of the breast cancer. It is such a vast topic that it is probably out of the limit of today's talk. So for the outline, I'll discuss the breast cancer risk factors, risk stratifications, screening recommendations for both average risk women as well as for high risk population, and talk about some of the cancer prevention strategies. So what are the risk factors? This is, a list of the risk factors: age, race, personal or family history of breast cancer diagnosis, and so on. So I decided to, divide them into two groups: the risk factors that are unalterable. So these include gender, of course. All women are at risk of developing breast cancer, and that includes age. Age between 65 to 75 is the highest risk factor for for breast cancer development. That's when most of the women are diagnosed with breast cancer. If you look at the relative risk, it's about 18. Family and personal history of breast cancer, that gives you a relative risk of about 3. 3 times if you did not have any family or personal history of breast cancer. Race, like I said, white women are at higher risk of developing breast cancer. Some populations, such as Ashkenazi Jewish population, is at higher risk of developing breast cancer due to various genetic factors. Some of the other races have higher mortality, as in African American women, and that also would probably go into the biology of the breast cancer in different racial population. The treatment with DES during the pregnancy, I guess it is a risk factor, but probably not anymore, since diethyl is not being used for management of pregnancy-related complications anymore. Ionizing radiation, again, it's used less and less commonly these days, but still women who were diagnosed with Hodgkin's disease and received mental radiation or other childhood cancer that required treatment with radiation to the chest and the chest wall are at risk for breast cancer. Reproductive history, which includes, nulliparity, and the menstrual history, early menopause, early menarche and late menopause is associated with higher risk of breast cancer. This is probably due to more years being exposed to estrogen. And I will talk about the relative risk of these each risk factors. Then one major risk factors are genetic factors, such as multiple genetic mutations, such as BRCA1, 2, PALB2, ATM, Lynch syndrome, genetic mutations, which one cannot alter, do increase the risk of development of breast cancer. And also prior breast biopsies, even whether they are premalignant or benign breast biopsies, increase the risk of breast cancer. There is a big discussion about breast density, and probably I'll go in a little bit more detail later on. So the higher the breast density is associated with higher risk of breast cancer, although we still don't know what causes the higher risk of breast cancer in these women. Is it just the detection problem versus actual high risk? Is a little bit unknown. Then we would uh, go to the alterable risk factors. That's something that we can do about. So in all women, as we know, obesity is associated with higher risk of breast cancer. In postmenopausal women, estrogen is made in fat tissue, and that is associated with higher risk of breast cancer. We know that nulliparity is also associated with breast cancer, as well as not breastfeeding. So breastfeeding is protective. During the breast feeding, the breast tissue goes through differentiation, and more differentiated breast glandular tissue is less likely to develop cancer in the future. Hormone replacement therapy is associated with breast cancer, which can be avoided. Alcohol use, I will go through the studies. It was kind of a bummer once we first heard about this study in 2017 from the nurses study, where it showed moderate alcohol use is a risk factor for development of breast cancer. Initially, it was dismissed that it might be just a coincidence, but then the second study came out showing that moderate use, anywhere from 5 to 9 drinks per week, was associated with 1.5 times the risk of breast cancer development. Birth control pills, the relative risk is relatively low, but again is associated with breast cancer risk. So this is, just the tabulated form of relative risk of various factors. BRCA1 and 2 mutations are probably conferring the highest risk. And I give the relative risk of anywhere between 3 to 70. That is dependent on the age where they are diagnosed with a carrier of these genes. Any family history, specifically mother or sister with breast cancer, gives you a relative risk of 2.6. Relative risk, I mean, is by 2.6 times the risk of average person. Any history of atypical ductal hyperplasia on a biopsy carries the relative risk of 3.7%. Age, as I mentioned, the most breast cancers are diagnosed between 65 and 75. Lower age of menarche, below 12, with the relative risk of 1.5. Higher the age of menopause, over 55, the relative risk is 2. Use of OCP is not, it's not, in our world, is not considered major risk, but it does have a little bit higher risk. HRT use is giving you relative risk of 1.35 if the hormone replacement use is only for 5 years. Beyond 5 to 9 years, the risk goes above 1.4, but not all hormone replacement therapy gives you at high risk for developing breast cancer. For example, if it is used in younger women after oophorectomy for less than 5 years, the risk of breast cancer development is no more than the average population. So I wouldn't say that if somebody is really suffering from menopausal symptoms, a couple of years of hormone replacement therapy is probably okay. Alcohol use, like I said, anywhere between 1.2 to 1.6, depending on moderate or heavy alcohol use. Breast density above 75% gives a relative risk of 1.8 to anywhere from 1.8 to 6 times the relative risk. And any benign breast biopsy gives a relative risk of 1.7 times. Moving on, just expanding on some of the risk factors. The family history, the first degree relative with breast cancer literally doubles the risk of having a breast cancer, developing the breast cancer. And more than one first degree relatives may increase the risk to 3 to 4 times. About 13% of the women diagnosed with breast cancer have a family history or first degree relative with breast cancer, but most of the breast cancer is sporadic. Like 70% of breast cancer patients do not have any family history, and we have to keep that in mind. All the cancers are genetic. There is some genetic mutations, but they are not all hereditary. So only 5 to 10% breast cancers are hereditary. And then there are 15 to 20% are considered familiar, where there is a family history of um, breast cancer, but there is no genetic mutation um, found which is associated with breast cancer. So it is an important risk factor for breast cancer. So these are the common hereditary susceptibility genes. Like I said, most common one is BRCA1 and BRCA2. The other genes are, P53 mutations, which account for about less than 1%. Most of BRCA1 and 2 are accounting for about 70% of hereditary breast cancer. Some of the newer genes that are being associated with hereditary breast cancer are PALB2. I did not include them in this graph, but then ATM mutations. So BRCA1, PALB2, ATM mutations are all involved in similar pathway of homologous gene recombination pathways. Then Lynch syndrome are also associated with breast cancer. And then there are multiple others and undiscovered genes that have been implicated in development of breast cancer, which are still being diagnosed and worked into it. So we divide, so what are the red flags for, hereditary cancer? So we take them as in the 3-2-1, 3 or more family members with same or similar type of cancer is a red flag. 2 or more generations affected by the cancer is a red flag for a hereditary cancer, or 1 or more cancer diagnosed before the age of 50 is a red flag for a hereditary cancer. And these are the patients who we actually recommend to have genetic counseling. These are the NCCN guidelines for genetic testing, suggesting any individual with the family history of BRCA1 or 2 mutation, patients, anybody who has personal history of breast cancer or onset before 45 or diagnosed before 50 with another primary, anybody who has 1 or more family member with breast, ovarian, or 2 or more relatives with pancreatic cancers are recommended to have genetic testing done. And patients who are diagnosed with breast cancer at an earlier age with limited family history are also encouraged to have genetic testing done. Triple negative breast cancers are most commonly associated with the BRCA1 or 2 mutation as well as P53 mutations. So any patients who has triple negative breast cancer below the age of 60 is recommended to have genetic counseling. 2 or more breast primary in single patients. So if somebody is diagnosed with bilateral breast cancer, that patient should be counseled for genetic testing, and close male relatives with breast cancer. Based on recent guidelines, nowadays we are testing pretty much every breast cancer with genetic testing, because if they are diagnosed with BRCA1 or 2 associated cancer or PALB2 associated cancer, they are candidate for PARP inhibitors, both in adjuvant treatment and metastatic breast cancer. So once a family member is diagnosed with genetic mutation, of course, we need to treat all the other family members, and that may, influence their screening for cancers. So expanding on some of these genes, BRCA1 and 2, which are most commonly mutated in breast cancer. These are, involved in DNA repair mechanism. BRCA1 is located on chromosome 17, and BRCA2 is located on chromosome 13. And the prevalence of these genes in general population is relatively low, 1 in 500 to 1 in 800. But in Ashkenazi Jewish ancestry, it is found in 1 in 40. And then in our own practice, I mean, we initially discovered, and then it's been actually found in many other centers, is Latino population has much higher prevalence of BRCA1 and 2 mutation. Some of the mutations that are found in Latino population is very similar to what are seen in European population, probably, signifies the migration of population in the earlier days. The cumulative risk of breast cancer and ovarian cancer increases with age. So, for example, by the age 50, 50% of patients who have these mutations are at risk for developing either breast or ovarian cancer. And by age 70, about 87% patients develop breast cancer, as opposed to sporadic risk of 2% at the age of 50 and 8% at the age of 70, and the ovarian risk in the sporadic population is less than 1%. And up to 44% in the patients who have these mutations. So the age where these carriers are identified affects the risk of development of breast cancer and ovarian cancer, and that will influence our recommendation for risk reduction. For example, if a woman is diagnosed with if the woman is actually identified as a carrier of BRCA1 or 2 mutation at age 30, her risk of development of breast cancer is up to 55% by age 70, and the ovarian cancer almost 40% by age 70, as opposed to if the carrier is identified at age 60, the risk of development of breast cancer by age 70 is only about 20%, not that much higher than a high-risk patient, and ovarian cancer about 22%, probably reflecting the fact that if she didn't develop the cancer by age 60, the remaining risk of developing breast cancer is not that much higher than in a population of her age. And that's the reason why we wouldn't recommend prophylactic mastectomy for a patient who is 60 years or older who has not developed cancer so far. So these are the common, so these days we do multi-genetic, multi-gene panels. The two most commonly used genetic panels are Embrace or Invitae in US, and they use, commonly associated gene panel. This is an Embrace panel of 17 genes. They divide them into a high penetrance gene, BRCA1, 2, TP53, PALB2, and then the lower penetrance gene, where the risk is higher, but not very high. We also need to be aware of the variants of unknown significance versus deleterious mutations, because more tests we do, more mutations we find, and most of these mutations do not have, pathogenic implications. So if somebody is found with VUS in any of these genes, they do not change the management of that person and does not change the risk category of that person. What is the difference between the low penetrance and the high penetrance gene? So high penetrance genes are the ones which have higher risk of development of breast cancer, over 50% if they are carried through, and definitely require risk modification. Low penetrance genes give you a higher risk of lifetime development of breast cancer, but it is more significant in the context of the family history. So, for example, a low penetrance gene such as CHEK2 or ATM gene by itself will give you 10% lifetime risk of breast cancer if there is no family history. But if there is a family history, same genetic mutation gives the risk of 60% of development of breast cancer, and it may actually change our screening and prevention strategy in these patients. So that's why it's really, really important to obtain the family history and actually interpret these genetic results in the context of the family history. Moving on to breast density. So breast density has gained a lot of press recently. This is how the breast density looks on the mammogram. The breasts which are almost entirely fatty or pretty, black, and any blood vessels or calcifications can be seen very easily. And as the density increases, and this density is due to the glandular tissue, by the time they become category 3 or 4, the calcifications or microcalcifications are pretty difficult to identify, and they may limit the sensitivity of regular mammograms. So women who have dense breast have been shown to have increased risk of development of breast cancer, and the relative risk for women who has more than 70% density is found to be about 4.6-fold higher than women who have less than 5%. The exact cause of the risk is unknown. It may be associated with more glandular tissue, but it is thought to be more because there are more missed cases and not undiagnosed cases, and they are diagnosed at a later stage. But once they are diagnosed from exact stage to stage, the mortality for patients who have high breast density with breast cancer is no higher than the similar stage of breast cancer in women who have lower breast density. So I think more research into the cause of the dense breast and actual cause of relative risk is still needed. These breast lesions are not easily detectable, like I said, with the regular mammogram. And therefore, sometimes adjunctive tests are recommended. These are not necessary, and they don't replace the digital mammography, but they can be used as adjunct to regular screening. Another major risk factor is benign breast biopsy. So the breast is a very hormonally reactive tissue. The breast cancer development is a continuum of different pathologies, from a normal ductal lumen to benign proliferative changes to atypical ductal hyperplasia, where you see some more atypia, to development of DCIS, and that can lead to development of invasive ductal carcinoma or invasive lobular carcinoma. Any biopsy that shows atypical hyperplasia, ductal or lobular actually, would increase the risk of further development of breast cancer by 4 to 5%. And it's not only where the hyperplasia is found. These changes are found in the entire breast and actually both breasts. So one diagnosis of atypical ductal hyperplasia increases the risk of development of breast cancer in any part of the breast and also in the contralateral breast. The recent study found that the risk of breast cancer increases by 1% each year from the time of biopsy, and the cumulative incidence of cancer is about 30% at 25 years from the diagnosis of ADH. So therefore, it is important to identify and we're recommending risk reduction strategies for these patients. Again, another risk factor is chest radiation. As I mentioned before, for the treatment of Hodgkin's disease, again, the risk is 7 times higher than the population. And there is the most vulnerable age is between 10 to 14. And after 40, this risk does not appear to be increased compared with general population. And also it is noted in early other childhood cancers such as Wilms tumor and Ewing sarcoma that require radiation also are at high risk for development of breast cancer. Another risk factor that we probably are all very, very familiar with, high body weight. And the obesity is associated with the risk of development of breast cancer in postmenopausal women. Mainly, I would say probably because the estrogen is made in the fat tissue in postmenopausal women with the aromatase, enzyme aromatase. And that is the one which is increasing the risk of breast cancer that goes up with the body weight. Lack of physical activity, again, is associated with higher risk of breast cancer. The physical activity it influences hormones such as, serum estrogen levels are a little lower in people who are highly active, and insulin growth factors and insulin levels are lower, which all stimulate cancer growth. So now moving to risk assessment, how do we assess breast cancer risk and then use those risk assessment tool and the results to personalize screening and risk reduction strategies? So there are multiple assessment tools that I will talk about. Three major ones. One is the Gale model, which is the most commonly used and available online, free of cost, and you don't have to register for that. So this model takes they account for breast diseases like ADH or LCIS in the past, onset of menarche, parity, family history. It does not include race, ethnicity, breast density, genetic mutations, etc. So this is how a screenshot of the Gale model assessment looks like. You basically, if you have, they ask you for a development biopsy of DCIS and BRCA1 or 2 mutation. And if DCIS is positive in any of the biopsies, it just gives a high risk and does not move the tool any further. But at the end of the day, after you answer all of these questions, the risk and the results come out like this. For this woman, 5-year risk is 1.4%, compared with the average woman risk. And it also gives a lifetime risk. And a 5-year risk of 1.6% or more is considered high risk. Because that kind of translates into the lifetime risk of about 20% or so. The other models that are used are Triacrusic model. This is similar to Gale model, but also includes the second degree family history, and the use of hormonal replacement therapy. It does predict more accurate risk, but it is cumbersome to use and requires registration. And the other one that is more for the it basically it predicts more hereditary or family history risk prediction is the cross model, and again a little bit more cumbersome and requires registration. So most of us use Gale model risk tool for most of our patients. Having the dense breast is considered moderate risk, basically extremely or heterogeneously dense breast as seen on the mammograms. And the categorization is the average risk, which is low risk, which is considered about 12 to 13% lifetime risk. The moderate risk is more than 15%, but less than 20%. And the dense breast come into that risk categorization. And the high risk is over 20% lifetime risk. So now moving on to screening, according to USPTF data, the screening by mammogram has shown to reduce the breast cancer mortality by 24%. And that is, a pretty high and very respectable number. This is a little bit more granular data specifically by the age group, and that might have led to their recommendations of screening mammogram. So according to their data, the risk reduction was not that significant between age 39 to 49. and the highest risk reduction was found between age 60 to 69. So these are the guidelines, of average risk screening for breast cancer. Um, uh, and USPTF guidelines were just revised in 2024. They have gone through at least 3 or 4 revisions in last 5-10 years. So the current guidelines recommend start screening by mammogram or digital mammogram at age 40. And they recommend to stop screening at age 75 because there is inadequate benefit of screening. USPTF recommend doing mammograms every 2 years unless there is any other risk factors, and they don't recommend any other adjunctive testing if the dense breast is found. Most of us use American Cancer Society guidelines or the American College of Radiology guidelines, and most of them are kind of similar. So American Cancer Society guidelines recommend starting mammography at age 45, but with an option to start at age 40. And they recommend to continue screening as long as the person is in good health and the life expectancy is more than 10 years, kind of like prostate cancer patients. The frequency is up to 55 years every year. And then after 55, if the mammograms have been normal and there is no risk, or the risk is relatively low, no family history, the screening frequency can be reduced to 2 years, but with an option of every 1 year screening. They do recommend either MRI, ultrasound, or contrast enhanced mammogram for an adjunct or a supplemental test for with mammography, but not as a replacement. American College of OBGYN and American College of Radiology and NCCI guidelines are pretty similar, starting screening mammogram at age 40, individualized after age 75. The frequency is every 1 year. And no specific recommendation, but follow the guidelines of American Cancer Society. If for dense and very dense breast, they do recommend to consider not hard and fast recommendation, but to consider supplemental ultrasound or MRI or molecular breast imaging for women who desire to do that. For the high-risk population is considered for women who have lifetime risk of 25% or higher, based on the risk assessment tools, which are mainly based on the family history, or if they have a known PCR1 or 2 mutation, or they have family history, first-degree family relative with BRCA1 or 2 mutation, but have not had the genetic testing themselves, or if they had radiation therapy to the chest between the age of 10 and 30 years of age, and or have other mutations such as P53, Cowden syndrome, or many other mutations, or have the family first-degree family members with these mutations. So for these people, if the lifetime risk is 20% based on the family history, then the NCCN recommend them to be referred to genetic counseling and maybe referred to a breast cancer specialist for appropriate screening. Their annual screening by mammogram is recommended to start 10 years prior to the youngest family member who was diagnosed with breast cancer. And they recommend to begin the mammographic screening at age 30, not before. Patients who have BRCA1 or 2 mutations, recommendation is to use annual mammogram along with MRI, with or without contrast, for screening. Patients who are not able to have or go through MRI, the contrast enhanced mammography or molecular breast imaging can be used for screening. And again, MRI should also begin 10 years prior to the youngest family member, age of the youngest family member with breast cancer. We strongly recommend risk reduction strategies for these patients, and breast awareness is important for this group of the patients. How about people who've had, or women who've had thoracic radiation? Mammographic screening is recommended at the age of 25 or 8 to 10 years after radiation was done. Annual MRI can be used as a part of as adjunct or a part of screening. And we can also, and the NCCN guidelines also recommend contrast enhanced mammograph or molecular breast imaging who qualify for MRI but are not able to go for MRI or consider whole breast ultrasound for screening. For patients who have breast cancer risk over 1.7, for 5 years breast cancer risk over 1.7, annual mammogram is recommended with the clinical breast examination, and the recommendation is to start at age 35 or whenever they are identified as high risk. In this population, MRI can be used but not always recommended. In women who had prior benign breast biopsy, which had LCIS or ADH, again recommended to have annual mammogram. And specifically in LCIS, one can consider MRI or as an adjunct to mammogram. Again, not replacing the mammogram, but using as an adjunct. And these patients are strongly considered to use risk reduction strategies. In patients who have history of breast cancer, prior breast cancer, annual mammogram every 12 months is recommended. And as I mentioned before, patients who have dense breast on mammogram, such as over 75% density, breast tomosynthesis is strongly recommended, and adjunctive tests such as whole breast ultrasound, MRI, or newer modality such as molecular breast imaging or contrast enhanced mammogram can be used. A clinical breast exam is sort of controversial. Here, the USPTF and American Cancer Society does not recommend clinical breast exam, but American College of OBGYN recommend doing clinical breast exam every 1 to 3 years. It is thought that breast exam plus mammography has higher sensitivity. So these are the general screening modalities. Digital mammogram is the most commonly used screening modality. Hardly anybody uses regular mammograms in US anymore. The digital mammograms are more accurate, but there is a higher rate of false positives. Breast tomosynthesis are being used more and more commonly. It is basically a digital mammogram with an X-ray tube that moves on an arc and gives you a 3D picture of the breast. And it can produce slices as thin as like 0.5 millimeters. Ultrasound can be used as an adjunct to digital mammogram for screening. Ultrasound itself is not a good modality for the screening itself. MRI, as we know, is recommended for high-risk women with the lifetime risk of 20% or higher. And the advantage is it can detect smaller cancer and give a much better idea, but at the same time, the high false positive rates are high. The two newer modalities are contrast enhanced mammograms, which combines the 3D tomosynthesis with IV contrast, and it actually shows unusual blood flow pattern in the breast, and able to identify malignancy versus a non-malignant enhancement a little bit better. Again, the downside is not available, and the IV contrast is actually ionizing contrast is used. And the molecular breast imaging is a nuclear medicine test, which uses technetium-99. and very useful in dense breast in identifying, a malignancy versus a non-malignant glandular tissue, but again, not readily available, and there is a concern for radiation exposure because of the technetium-99 tracer. So this is a mammographic finding on for breast cancer, either a mass or the microcalcifications. So what can be used to prevent or the strategies for risk reduction? So I'm going to talk about the ones that are proven benefit, or the strategies that have proven benefit, and then some recommended strategies, I would say. So the chemo prevention with tamoxifen and raloxifene. So this is based upon the NSABP P1 and P2 trial. It was done in 90s and early 2000. About 60,000 women were randomized who had Gale model breast cancer, 5-year risk of 1.6 or higher. And they were randomized between tamoxifen and placebo, and in P2, tamoxifen, raloxifene, and placebo. And women who had, and these patients were, they were not cancer patients. They just had higher risk, and the tamoxifen reduced the risk by 38%. And that included both in situ and invasive cancer. And the invasive cancer risk was reduced by 50%. The tamoxifen was superior to raloxifene, and raloxifene did not prevent in situ carcinoma. However, tamoxifen was associated with more side effects such as endometrial carcinoma and abnormal uterine bleeding and DVT. Raloxifene was not associated with uterine cancer. Now we understand that more and more data is coming about the dose of tamoxifen. So probably we don't need to use the 20 milligram dose for prevention. Lower dose 10 milligram is as effective, and even 5 milligram dose is as effective in prevention. In my practice at this time, I do not use 20 milligram tamoxifen for prevention. I use 10 milligram. 5 milligrams is not available. So patients who are not able to tolerate can actually even take 10 milligrams every other day. And these will be situations as somebody has ADH or LCIS. The other agent is aromatase inhibitor, anastrozole or aromasin. Again, in similar population, it reduced the breast cancer risk by 53%, and there is no risk of DVT or uterine cancer, but these drugs are much harder to tolerate as they reduce bone density and cause significant arthralgias. Now, the surgery. So surgery is recommended, basically bilateral mastectomy, prophylactic bilateral mastectomy would reduce the risk by 95%. In patients who have breast cancer and are associated with high penetrance gene mutations, such as BRCA1 or 2, the contralateral breast cancer risk is about 65%. So, we do recommend bilateral mastectomy if the patient is diagnosed with BRCA1 or 2 mutation. If somebody goes through bilateral mastectomy, no further radiological screening is recommended. But if the person chooses not to do surgery, then the MRI screenings are recommended. Preventive bilateral salpingo-oophorectomy would reduce the risk of breast cancer by 50%, especially if it is done between 35 to 40 years after childbearing is done. And of course, it will reduce the ovarian cancer risk by 90%. And also, all-cause cancer mortality risk is also reduced by about 70% after bilateral salpingo-oophorectomy. So again, these strategies are for high risk and very high risk women. Again, you would not recommend it for everyone. Again, this is for everyone. Physical activity, A review of about 73 observational studies revealed that moderate to vigorous exercise reduced breast cancer risk by about 25%. The optimal level of physical activity is unclear, but the major limitations are that these are observational studies and based on the self-report. And management of weight and BMI is, reduction in the weight is associated with improvement in breast cancer risk. As I mentioned before, a high BMI is associated with high risk. Estimated each 5 kilo per meter squared increase in BMI is associated with about 12% higher breast cancer risk. So weight management is definitely a good preventive strategy. And these are some of the controversial preventive strategy. One is metformin. In diabetic patients who are on metformin, lower incidence of cancer is reported. And the mechanism is probably due to lowering serum insulin, inhibiting downstream signaling pathways through AKT and the RAS-MAP kinase pathways, leading to decreased cell proliferation. There was a study where in patients who were diagnosed with breast cancer and metformin treatment reported actually decrease in BMI, and on surgery, tumor cell proliferation like Ki-67 index went down. So there are some studies suggesting that there might be a role of metformin in prevention of breast cancer, but again, not recommended. The only thing I do in my practice is if somebody is diabetic or a pre-diabetic and requires treatment, I choose metformin. Again, another controversial agent is vitamin D. Some of the studies suggested that especially in premenopausal women who take vitamin D have the lower risk of breast cancer. And in postmenopausal women, if the vitamin D level is over 40, their risk of breast cancer development is lower. There is one observational study that showed that higher intake of vitamin D was associated with lower risk of premenopausal breast cancer. But again, it's not recommended, controversial, but probably low risk intervention. And aspirin use has been also associated with a lower risk of breast cancer. Again, not to the level of prevention in colon cancer, but somewhat lower risk. So are there any harms from screening? There is always a risk of false positivity and unnecessary diagnosis with the with mammograms, which can lead to anxiety. Also, there is a notion of possibly we are overdiagnosing some lesions that would have never led to a morbidity or mortality, and especially some low-risk DCIS, which would never have bothered a woman overall, but there is no way of actually quantifying right now. There are some studies ongoing where patients who have very hormonally positive DCIS are being observed, and we may find more information going forward. But this is definitely one of the negatives of overscreening and a possible radiation. So in conclusion, early detection has been shown to reduce breast cancer morbidity and mortality. And and we should consider prevention in patients with high risk for developing breast cancer. And with this, I thank you for your time and listening to me. And this is the picture of my institution. Thank you so much.
Thank you, Dr. Agarwal. That was a great presentation, very comprehensive. I just have a few comments, about the mammogram screening. Even USPSTF, the Prevention Task Force, recommends every year mammogram. It used to be every 2 years, but in April of 2024, they changed that to every year. So
No, actually,
majority of them.
It's the other
Yeah,
way
go ahead.
around. So the previous guidelines were every year between 40 to 50. and then every 2 years after 50. But this year in April, they changed it back to every 2 years.
I understood it's they change it every year, but yeah.
No, that
anyway.
I thought so also, but I did my research in creating this
Sure.
presentation. So
Okay.
this is the newest one right now.
Very good. So the moderator today, Manmita Ahluwalia, actually they're having a storm in Florida. We pray for their safety.
Oh
So
no.
I'll be the moderator. If there's anything, please put in the chat box. One question Dr. Jaswant Jain asked: if mammogram and MRI breast are negative, and patient has dense breast with history of breast cancer in sister, does she still need ultrasound?
No. So if the MRI is negative, completely negative, and mammogram is completely negative, I don't think the ultrasound adds anything more in that patient. In the ultrasound would add only if MRI is showing something. The second look targeted ultrasound would add the area which could be probably biopsied under the ultrasound guidance, but will not give any more information. So if one has to do something, I would say go for molecular breast imaging. But again, if the MRI is negative, there is really no role for another imaging.
Okay. So Dr. Meher Medavaram asked a question: molecular breast imaging is not covered by most insurance companies. Would you recommend whole breast ultrasound for all dense breasts?
So this is, again, a very controversial issue. The whole breast ultrasound is cumbersome, and not every center is actually equipped to do it. It requires a lot of manpower to do a whole breast ultrasound. And many insurances are not covering that. So it depends what is the other risk factors and taken everything together. So if one is doing digital mammogram or tomosynthesis every year, the value of adjunctive tests are actually relatively lower. But this is a conversation that has to have between the patient and the provider. It's not uniformly recommended to do a whole breast ultrasound or MRI.
Okay. So Dr. Maltivich has a question: how should MRI be done for dense breasts?
I'll tell you what I use or what we use, and so that is because of the lack of proper guidance here. So generally, you would do a digital mammogram or tomosynthesis, and if the breasts are dense, one could use alternative MRI and mammogram. So you can use 1 year mammogram followed by an MRI. And generally speaking, if the MRI is negative, you can repeat the MRI every 2 years or every 3 years.
Yeah, that's very true in low resource countries like India, where it's very difficult to get a mammogram, and if it is negative, doing every 2 to 3 years is very reasonable, because every year without any abnormality is an overkill sometimes.
Actually, there was
But
a
again,
very interesting research presented in San Antonio Breast Symposium a few years ago from Europe, where they did not use mammogram, but used MRI every 3 years, and then compared it to the population that was using digital mammogram. And the MRI screening every 3 years was equivalent to mammogram. Again, I would not say to adopt it in US, and they didn't, it's not recommended, but there is some data about that.
Yeah, I mean, Europe does some innovative things, but here there is a liability issue. I think that also is taken into consideration. That's why we do yearly mammograms, I guess. But in low resource countries, there's also something called, iBreast exam, which is a handheld device. It's very portable. It can be done with, done by healthcare workers with good accuracy, not like mammogram, but it's much better than self breast exam or even clinical breast exam. So, it's a device that is being used more commonly, even here in a low resource setting like rural areas where they don't have any mammogram. So that's one modality that is existing, but it's not FDA approved, but still people are using it in some countries.
So the
So,
question, so the one thing that you wouldn't see is the tissue, the cancer which are not palpable. So
mhm,
if for a tumor to be palpable, it's already quite big, and
right.
mammogram detects calcifications where the tumor is not palpable. So you will miss pretty much all the DCIS by that exam.
Yeah, yeah, that's true. But I'm talking about people where there is no mammogram. They can get at least that, which is better than a clinical
Definitely,
exam. Yeah, yeah.
definitely something is
So,
better than nothing. Yeah.
yeah, yeah. So another question here: can you apply a baby TAM study, low-dose tamoxifen, to DCIS or low-grade tumor who are not able to tolerate full tamoxifen dose?
Good question. And we all are actually thinking about it, but there is no data of baby tamoxifen to DCIS or invasive cancer. The baby tamoxifen study was done only for, ADH and LCIS population and was very useful. So I don't know whether, I don't have any data to support use of low dose tamoxifen to DCIS and invasive cancer population.
Okay. Another question: ADH is a spectrum. When do you not recommend chemo prevention? Is there any place that you don't recommend chemo prevention?
Well, when the patient says no to taking, no, because if we are recommending chemo prevention for people who don't even have it, DCIS, so, patients who have ADH or LCIS, we're recommending chemo prevention. So for patients who have DCIS, I would say no. Yes, we can use chemo prevention, and there are studies to suggest that can we not do surgery or can we not do radiation? Would that give you the same results is a question, because what is happening in DCIS in one part of the breast is also happening in the rest of the breast. So unless patient refuses, I offer to everyone. The only other
I
patient
mean,
I will not recommend is if the DCIS is ER negative.
yeah, that's true.
Yeah.
So, but it can prevent other cancers. But if the DCIS is ER negative, then you may say that it can prevent other ER positive breast cancer if the patient is at high risk.
It's yes, but the chances of the next cancer being ER positive is lower than ER negative cancer.
Sure,
And
sure.
it's been studied in DCIS studies in NACBP.
Yeah. So there's also disparity between the screening, globally speaking. The mammogram uptake rate in the US is 90%, whereas in India it's only 1%. So there is not enough emphasis on screening in India. I think there is a huge
Yeah,
chance to improve that, to prevent
definitely.
breast cancer. Yeah.
Definitely. I actually was looking for the numbers in India to, the similar statistics. I couldn't even find a reliable statistics. There are multiple studies to say, they looked at 10 hospitals in South India or 15 hospitals in, West India. So, but none of them gave me, the incidences or the statistics in all over India that is believable.
I mean, there is no cancer registry in India. I mean, that's what needs to be done, and
Yeah.
also the screening, procedures and things like that. There should be emphasis. That's what we are going to focus on in this Global Health Summit. We're going to
Definitely.
have, in the next 10 days or so.
Yeah.
But any other questions, please put in the chat box. I think there is another one. We would follow up with another Indian landscape. Okay. So that's wonderful, Dr. Agarwal. Thank you so much for enlightening us today about the screening and high-risk population and the prevention strategies. And it's really time to educate us. Amit, thanks for the introduction, being the CMA chair. So, and we wish everybody a very happy Navratri season. And we have a small token of appreciation for Dr. Sangeeta Agarwal. Ms. Vijay, can you put that?
Yeah.
So, yeah, here is
That is
the
really
American
sweet.
Physician.
Thank you so much. Yeah.
American Association of Physicians of Indian Origin recognizes Sangeeta Agarwal, MD, for her outstanding contributions in the field of oncology and hematology, and welcomes her as a member of API Distinguished Speakers Club. Satish Katul, API President, Amit Govil, Chair of API CME Committee. So thank you, Dr. Agarwal, again. And thanks to all the attendees who took their time to attend despite the Navratri season. So, and you all have a wonderful night.
Thank you so much. Really appreciate.
Thanks.
Yeah.
Thank you, everyone.
Thank
Thank you. Take care.
Don't forget to sign in for that CME. And if you fill that sign-in sheet, then you'll get an email with evaluation form. And after you fill the evaluation, you get the CME certificate. It's pretty easy process. So try to get that credit. Thank you all.
Thank you.